So thanks a lot, Mackie, for your nice presentation. We still remember your workshop. We have a lot of questions, and I think Dr. Richard Polin connection is lost, so he's not with us. So Dr. Huston, there are a couple of questions for you. Uh, how early you can diagnose the failure to thrive, preemie?
Well, in the NICU now, particularly in North America, and I think this is going on in other countries as well, there have been some guidelines published. It was the first reference that I listed on my references, the Goldberg paper, are guidelines on diagnosing malnutrition in the NICU. And it's based upon, again, using the changes in Z-scores for weight gain during the baby's hospital stay. So they look, as the dietitians follow the infants in the NICU, when they do their evaluation, they're computing the change in Z-score at the time they're being evaluated compared to the birth weight. And if the change in Z-score is more negative than minus 1.2, that's moderate malnutrition. If it's more negative than minus 2, that's more severe malnutrition. And then that guides them as far as their interventions are concerned. There's some other criteria that they list as well, but that's the primary one that they use.
Thank you. Mackie, how many ultrasound you recommend to learn the point of care ultrasound, especially for like IV insertion or line placements?
Yeah, well, so right now, as you know, as I mentioned, there are no like standardized guidelines for this for training. So really, they are based on every institution. So at CHOP, what we require to become, credential, we ask for 25 studies per application. Let's say you're doing lung, you need 25 studies reviewed by someone who is already credentialed with feedback and all that. So, and that's for the diagnostic piece of ultrasound. For the procedural aspect, is different because all of us neonatologists, we're all credentialed to do procedures, right? We all do all of them blindly. But then, using ultrasound to help yourself guide and be accurate and effective when placing lines, it's just a matter that in that way we do not ask for a number because it just really is based on your personal skills and how quickly you pick up that skill of using ultrasound to help guidance. So there are not really a number of studies required for procedural ultrasound.
Okay, thanks, Maggie. Dr. Huston, there is a study, according to one participant, by the Professor Nina Moody from UK, and she recommend not to fortify. Do you have any comment? Do you went through that study?
I'm not sure if I'm familiar with that study. I know there was a study from Canada, I believe, where they did not fortify initially until very late. And but most recommendations now are to fortify, just because we do know that the nutrient intake, particularly protein intake, and as well as, we're recognizing more with regard to fat intake and caloric intake, really does affect the neurodevelopmental outcome. And we do know that mother's milk without fortification just doesn't meet the requirements that babies have at this early gestation.
Okay. Oh, so Dr. Polin with us now. Dr. Polin, there's a question from the participant that what is the best laboratory investigation? I think they are asking about what is the best sepsis marker in newborn.
So it's a great question, Junaid, and I don't know if I have a good answer. The standard sepsis markers which are C-reactive protein and procalcitonin, and maybe IL-6 someone is using, have a poor positive predictive accuracy. Most of them have a fairly good negative predictive accuracy. So if you want to use them to reassure yourself that your physical examination is compatible with the baby being well, it's okay to use it that way. But I would not use any of the markers to say a baby is infected, because again, the best they can predict is about 30% or so, and they miss a large number of babies who are actually infected.
Maggie, there is a question about the lumbar puncture.
Yeah.
Do you recommend the ultrasound for the lumbar puncture?
Well, in many cases, yes. So right now we are using it when the resident had a failed attempt, basically. Mm-hmm. But there are many cases that is useful to take a look before doing a lumbar puncture blindly. For example, to check the presence of fluid, right? Sometimes, you know, the fluid is not enough and the baby might need a bolus or something like that. How many times we have like dry taps. But currently we are not using it as a first attempt just because the residents need to do it. But if I had to do all the LPs, I would always use ultrasound because it is so much more successful. But so that's my recommendation. If you ask me, I would say, well, sure.
Sure.
Always use it.
Related to this, Dr. Polin, to do or not to do the LP?
Sure. Most of the time, I prefer not to do an LP. Okay. So my indications are, we know that a certain percentage of babies with meningitis had negative blood cultures, probably like 30%. So blood culture is an unreliable way of making the diagnosis of meningitis. In a well baby, the data are pretty clear that the incidence of meningitis is very, very low. So if a baby appears well, is having a rule-out sepsis evaluation, meningitis is not likely. I would do an LP in any baby with neurological findings or with whose clinical course is unusual. They're not getting better with antibiotics. Or I would say who is running very unusual lab values, maybe a white count of 70,000 or something like that. And the baby, it just is not fitting in the usual baby with a rule-out sepsis evaluation. And then I would consider doing an LP. But most of the time, and any baby with a positive blood culture obviously needs an LP. Most of the time, I do not do lumbar puncture.
Dr. Huston, there's a question about the stratification. I mean, you already mentioned in your talk, but one of the participants asking that, so the breast milk is the best, then the donor milk, and then the formula. This is the stratification or the order?
Yes. I mean, currently, you know, the recommendation, if possible, is to use mother's own milk. And then if out of mother's own milk, the preference is to fortify with donor bank breast milk. But if that's not able to be done, then preterm formula. It would be the other resort.
There's another question that how long you recommend to fortify the breast milk after the discharge. So let's say 25 to 26 week of discharge at about 34, 35 week of gestational age. So after discharge, how long you recommend to fortify the breast milk?
Yeah, that's it's a good question, and it's one where really it's an individual. Each individual baby is a little bit different, but generally the criteria, if the baby is still considered to be, you know, needing catch-up growth, and particularly if the baby has evidence of osteopenia, elevated alkaline phosphatase, low phosphoruses, then continued fortification post-discharge is recommended. If the baby's doing well and appears to be within a good range with regard to growth and otherwise feels stable, then just going to let the mother advance her breastfeedings, and using breast milk is recommended. a lot of the extremely preterm babies need a little bit of fortification, and sometimes the recommendation will be to maybe fortify 2 or 3 feedings per day if possible, and then have the mother work on breastfeeding the other feedings.
Okay. Question for Dr. Polin, that what do you think about empiric antibiotics? Mostly starting penicillin, gentamicin, or ampicillin, gentamicin, but there's some, I think this is from some other country, they said that in their setup, they are using ampicillin cefotaxime. And you mentioned that the 3rd generation is going to have some problem and then high mortality or this thing. So do you have any comment on that?
So clearly cefotaxime is great for gram-negatives, for gram-negative meningitis. Either cefepime or cefotaxime are drugs of choice. But there are these observational studies that 3rd-generation cephalosporins have been associated with an increased mortality. The only time I use cephalosporin, ampicillin cefotaxime, is in a baby whose mother got a lot of magnesium during labor, because we know that aminoglycosides like gentamicin can cause neuromuscular blockade, and especially in the setting of high magnesium levels. So if I'm concerned about hypermagnesemia in a newborn baby, especially a preterm baby whose mother received magnesium, I might use cefotaxime for that rollout. And all of our other babies, we use an aminoglycoside. Usually gentamicin is our choice.
Okay. So this is a very interesting question for Becky, and this is not from me. You opt not to answer that. Somebody asked that what probe you recommend, which company probe you recommend?
What company what?
The probe, the ultrasound probe for doing the POCUS.
Yes.
Which probe you recommend?
Oh, what what machine do I recommend?
Yeah.
I can tell you what we use, but there are many options. First of all, what I recommend is a portable machine, which is
Okay.
a small machine that you can take everywhere in the unit.
Okay.
So, you know, and every brand has these portable machines. And we have, or we use Philips, the CX50, which is a portable and it's a very nice one. We also have GE in the unit, and we also work with have Sonosite. So
Okay.
all of them are really good options, as long as they are small and that you can carry with you everywhere.
So because of the timing, there are a lot of questions, so I can catch Dr. Polin tomorrow again. And for Mackie and Dr. Huston, we will email you a lot of questions. So because for the time constraint of this setup, we have to end the session now. So thank you very much, all 3 of you. Really very nice and very interactive session. Thanks a lot, Dr. Robert Huston. Thanks a lot, Mackie. Thanks a lot, Dr. Richard Polin, for your time and for your talk this evening. Evening here, morning there.
Yeah, thank you for inviting me again. And I hope I wish I could go back to Abu Dhabi.
Of course, it depends if the favorite politician of Dr. Polin win or not. So it depends on that.
You're right, Junaid. Thank you.
Thank you very much. I hope to visit your country at some point.
Thank you. Thank you very much.